Welcome to this explainer. Today, we're diving into a grave, highly methodical medical emergency, one where velocity literally determines survival. We're talking about sepsis. It's an invisible crisis, and it plays out in hospital wards and emergency rooms around the world every single day.
So think about this for a second. How does a totally normal, everyday infection, like a scraped knee, a run-of-the-mill urinary tract infection, or a mild case of pneumonia, suddenly spiral into a deadly systemic threat? Well, to really understand this, we have to recognize that in these critical moments, a ticking clock has essentially just been initiated.
According to the Mayo Clinic, sepsis is a serious condition where the body responds improperly to an infection. The absolute most crucial point here is that it's not just the invading bacteria or virus doing the damage. Instead, the body's own infection-fighting processes turn on the body itself, causing vital organs to function poorly. It's like the body's shield suddenly becomes a weapon against itself.
Now, what makes this so incredibly tricky, so insidious, really, is how incredibly vague the warning signs can be. We're looking at things like a sudden change in mental status, fast and shallow breathing, sweating for absolutely no clear reason, maybe shivering or just extreme sleepiness. But medical literature, especially from pediatric practices, highlights something called clinical gestalt. That's basically a fancy term for a parent or caregiver's gut intuition that a child is simply not acting right. And get this, that gut feeling is literally treated as critical clinical data by doctors. Seriously, never ignore that intuition.
Because if sepsis is missed, it progresses to this, septic shock. This is defined by a dramatic and severe drop in blood pressure that fundamentally starves vital organs, like the lungs, kidneys, and liver, of oxygen. The data from the Mayo Clinic on this is frankly sobering. Progression to septic shock carries a staggering 30% to 40% mortality rate. We're talking about a true, complete systemic collapse.
And this systemic collapse isn't just some rare freak occurrence. This is a massive global issue. Data put together by the World Health Organization and the UK Sepsis Trust really shines a blinding light on the sheer scale of this invisible threat, highlighting the urgent, desperate need for responsible management globally.
Globally, the World Health Organization reports that sepsis is responsible for 1 in 5 lives lost. Honestly, just let that sink in for a second. 1 in 5. Out of the estimated 49 million cases that happen every single year across the globe, 11 million result in death. That is 20% of all global deaths linked to this one single condition.
If we narrow our focus specifically to the United Kingdom, the statistics are just as stark. Out of at least 200,000 adult episodes of sepsis each year, the condition claims approximately 48,000 lives annually.
To put that into perspective, when you stack the numbers side by side, the reality hits hard. Sepsis kills more people in the UK than bowel, breast, and prostate cancers combined. Yeah, combined. It even claims more lives than lung cancer, and yet somehow it rarely gets the same level of public awareness or airtime.
Beyond the immeasurable human tragedy, there's a massive economic burden here too. The direct cost to the UK's National Health Service is estimated to be between £1.5 billion and £2 billion each year. That accounts for a full 1% of the entire NHS budget. And when you factor in lost productivity and broader societal costs, that economic impact balloons all the way up to £15.6 billion.
So how exactly are doctors fighting back against this? Well, recently there's been a massive medical paradigm shift. For decades, the gold standard was the CIRS criteria, which essentially looked for systemic inflammation. But the problem was, it was overly broad. It frequently captured totally benign, self-limiting viral infections, which really diluted its usefulness in a clinical setting. Now, we use the 2024 Phoenix Sepsis score, which is highly precise and focuses strictly on quantifiable organ dysfunction.
Let's actually break down how this score is calculated. The Phoenix Sepsis score categorizes failure across 4 critical systems by measuring very specific markers. So things like blood oxygen for respiration, mean arterial pressure for the cardiovascular system, platelet counts for coagulation, or a coma scale for neurology. A score of 2 or higher in these categories, in the presence of an infection, doesn't just suggest sepsis, it absolutely confirms life-threatening organ impairment. It brings this incredible level of precision right to the patient's bedside.
Okay, so once that diagnosis is locked in, everything changes. The ER shifts into what's called the zero delay standard. Because when your blood pressure is tanking and your organs are starving for oxygen, time is literally tissue. This kicks off the single most critical window in sepsis management, the golden hour.
The speed required is just relentless. We are talking about the 60-minute resuscitation bundle. You secure vascular access in the very first 5 minutes, you draw blood cultures immediately after. By minute 10, you begin aggressive fluid resuscitation, and before that hour is up, you administer antimicrobials. The medical literature explicitly mandates that these interventions have to happen in a parallel processing model, meaning they must happen simultaneously, not sequentially, one after the other.
Let's dig into that fluid resuscitation protocol for a second. Clinicians have to administer 10 to 20 milliliters per kilogram of isotonic crystalloid, which is essentially rapid, balanced saltwater fluids via rapid push. A standard IV gravity drip is way too slow for this crisis. But it's an incredibly careful balancing act. Doctors have to constantly reassess heart rate and perfusion after every single push, and they have to completely stop fluid loading if markers of fluid overload appear, like pulmonary rouse, which is this crackling sound of fluid building up in the lungs, or an enlarged liver.
Simultaneously, doctors are executing the antimicrobial loading strategy. And get this, any delay in antibiotics is a linear predictor of mortality. For lower-risk community cases, they use a drug like ceftriaxone. For high-risk or hospital-acquired shock, it requires dual therapy, adding vancomycin to attack resistant bacteria like MRSA. But crucially, to maintain antimicrobial stewardship and fight off the rise of superbugs, there is a mandatory de-escalation of these broad-spectrum drugs at 48 hours once the specific culture data comes back. Now you might be wondering, how does this incredibly rigorous, resource-heavy timeline actually play out in reality when resources are super constrained? Well, there's a fascinating paper from the Algerian Journal of Medical and Health Research that looks exactly at this, adapting these strict criteria for secondary care pediatric wards that face severe resource limitations.
A really brilliant example of this kind of diagnostic agility is capillary refill time. In a fancy, fully equipped hospital, you test blood lactate levels to see how well tissues are clearing metabolic waste. But what if the lab machine is broken, or you just don't have one? The Algerian protocol mandates using a simple bedside test, capillary refill time. If you press on a patient's skin and it takes more than 2 seconds for the color to return, that is a robust proxy for hypoperfusion. This incredibly simple, immediate bedside test literally becomes a lifesaver.
They also tackle the biggest bottleneck of all, getting IV access in tiny, collapsed veins during pediatric shock. They implement something called the 90-second rule. If a standard peripheral IV fails after 2 attempts or 90 seconds, clinicians must immediately default to intraosseous or IO access. This means using specialized equipment to deliver fluids directly into the bone marrow. It just highlights the brutal efficiency required here. You absolutely cannot waste time searching for a vein while a patient is actively dying in shock.
Finally, the protocol lays out absolute mandatory escalation triggers. If the patient isn't stabilizing, if they're showing signs like requiring blood pressure medications, needing intubation, or experiencing a drop in consciousness, they must be transferred to intensive care immediately. The paper makes it crystal clear to frontline clinicians. Waiting around for an ICU bed to open up is never, ever a strategy. Aggressive stabilization is the only option.
As we wrap up this explainer, I want to bring it back to a quote from the WHO Director General that reminds us of the big picture. Defeating sepsis requires a coordinated, global structural response. It requires better health information systems, access to rapid diagnostics, and affordable medicines for everyone. But remember, all the systemic improvements in the world still ultimately rely on one localized factor: clinical vigilance. So, after all of this, the ultimate question is, do you actually know the warning signs? In this insane race against the ticking clock of sepsis, the boundary between survival and total tragedy very often comes down to cognitive readiness. Recognizing that someone is just not acting right and actually thinking to ask, could this be sepsis, could be the very first step in saving a life. When the clock starts ticking, will you be ready?